Conversations in Frailty, the podcast for Derbyshire clinicians.
Welcome back to the second episode in the series in which I get to interview our local heart failure lead about how we diagnose and refer heart failure. For those who are joining us for the first time, I'm Dr. Sarah Morris, GP by background, working within Derbyshire's Community Health Service Trust. Big thanks to those of you who've sent in such positive feedback after my first episode on Parkinson's. And I have taken on board thoughts that slightly shorter episodes are preferable. And with that in mind, I've recorded a separate episode to cover heart failure management. So I'm delighted today to be talking to Martin Melville, heart failure guru of the county. Over to you, Martin. Will you introduce yourself to the listeners, please?
Thanks, Sarah, for inviting me along today. My name is Martin Melville. I'm the service lead for community heart failure and cardiac rehabilitation services in Derbyshire. I've been a heart failure specialist nurse myself for 20 years. Outside of work, I'm a keen walker, rock climber, and I enjoy photography as well.
So your heart's probably quite good condition.
Hopefully.
We hope. Excellent. So today we're focusing particularly on the diagnosis and referral around heart failure management. There will be a following on episode where we talk about management and monitoring, so watch out for that. But today it's the diagnosis and referral we're going to think about. And just in the background, we're going to have Penny and Rita, a couple of imaginary patients who will follow a little bit through their journeys just to try to bring some of this to life. I would, at this point, sort of signpost you that we do have some excellent guidelines in Derbyshire. So both the Shared Care Pathology website, if you just put in Shared Care Pathology Derbyshire in Google, that will come up. There's 4 helpful pages focusing around management with a great summary flowchart. And the Derbyshire Medicines Management website has a slightly more daunting 17-page document. However, again, it's got a very good summary flowchart and lots of useful tables. If you want to go into the nitty-gritty of some help with prescribing and so on, they're the place to go. But these are reference guides, and what I want to do today is talk about how we apply this, particularly in the frail elderly, where, as we know, the guidelines often haven't really been written around them and don't always apply to them. Well, as a clinician, what do we mean when we talk about heart failure?
Okay, so as a clinician, heart failure is a clinical syndrome, and to that there are 3 parts. We have the symptoms that the patient comes and tells us about, the signs that as clinicians we see in our patients, and the third component of the diagnosis is that we should identify or see structural or functional abnormalities within the heart, which would commonly be seen on an echo but might be seen on other forms of cardiac imaging that we would choose. So that's how we think about it as a clinician. Okay.
And what about as a patient? Because sometimes we pick up this diagnosis in primary care and sometimes it's diagnosed within primary care. How would you explain to patients or maybe carers sometimes without alarming them? Because it's quite an alarming phrase in some ways, isn't it? Heart failure.
Yeah, so I think of it in a variety of ways, and it depends what type of heart failure we're talking about. So if we're talking about heart failure with reduced ejection fraction, I have 2 ways of talking to patients. Most patients have heard of a Jaguar with an XJ V6 engine in, and most patients have heard of a Fiat Panda with a 3-cylinder straight. Both those cars are good cars. They will get you from A to B. They will get you up hills. But as we all know, the Jaguar with its V6 cylinder engine will drag you up the hill in luxury. The Fiat Panda may struggle a bit. I often say to patients that really what's happening is your heart is simply failing to deliver the goods as well. And we're more like a Fiat Panda than a Jaguar V6. However, treatment can help along the way trying to get you back to being a Jaguar V6, but we have to see how we go. I should add at this point, there are other similar cars of similar brands. Another way of explaining this, which helps also explain heart failure with preserved ejection fraction, or what we often refer to as stiff heart failure, is a balloon model. So I think of the time, a year after a party occurred, I discover one of my daughter's birthday balloons down the back of the sofa. Looks a bit grubby and it feels a bit old, and I blow it up in the air, bursts in, the balloon expands, but when I let go of it, there's not a lot of power. It doesn't really eject a lot, and it kind of flops on the floor a bit early. So I go and find my new balloons, and I go and blow one up, and I inflate it, but then I can't get more air into it. I've got a stiff balloon. So the air's going in, and when I let go of it, it takes off quite well, but I didn't fill it with as much blood air, because of that resistance. And to me, that's the difference between reduced ejection fraction or weak heart failure and preserved or stiff heart failure. Those two balloons, the old one and the brand new one is weak, one is stiff.
Okay, and that's really, I like, probably the balloon one sits more with me, but I'm not a car expert, but I'm sure there are people out there who are the other way around, so that's fantastic. Okay, so introducing then our patients. So we have today Rita reduced and Penny preserved. So these are two 85-year-old ladies, and apart from the different types of heart failure, they're basically identical. They're living at home and they've rarely seen a GP. Each of them's recently had a fall, unfortunately, so the district nurses have been out dressing a laceration to their lower leg, and they come along to one of the clinicians saying, actually, I'm a bit concerned about the leg swelling for this lady. So on to sort of symptoms and signs here. Obviously, you're out there listening thinking we're suspecting this patient has heart failure, but what else should we be looking at, Martin? Because sometimes it's quite a vague presentation and there's a lot of overlap. So what would be the key things you'd be...
Yeah, I guess the three cardinal symptoms we often talk about are breathlessness on effort, swelling of the ankles or lower extremities, and fatigue. They would, to me, be the cardinal symptoms. But there are many others that we should give consideration and pull in as well. So other typical symptoms relating to breathlessness might include paroxysmal nocturnal dyspnea, PND, or orthopnea, where the patient tells you, I have to keep propping myself up on more pillows at night time, I can't breathe lying flat. The patients would also typically refer to reduced exercise tolerance. I can't go as far as I used to, or it's taking me longer, I have to have a sit and rest after I've done the hoovering far longer than I used to. Obviously, when they come along for examination, we have quite specific signs. Unfortunately, they're not terribly commonly seen, but we're looking there for an elevated JVP, a third or fourth heart sound, and if we palpate the chest, we might feel the strength of the apex beat has moved round to the left lateral wall. But those are things that we would have to find as clinicians. Those more subtle signs that you mentioned, symptoms that you mentioned, Sarah, might include things like a nocturnal cough.
Okay.
They might include, and I probably come across this more often than I'm aware, but nocturnal diuresis. And often the patients think it's, you've put them on a water tablet and that's the problem, and actually probably what they need is more. And indeed, I spoke to a patient this morning who I started on a drug that happens to have a diuretic effect, and he said, I'm sleeping for 6 hours through the night now. I was getting up every hour and a half rigidly. And I'm sure it's because we've reduced his natriuretic peptides and he now doesn't have that need to pass urine at night time.
And thinking here, a common mistake we're probably also making is assuming that's his prostate.
Indeed. So it's thinking of both, has it
really
been
helpful.
pre-existing or not?
Yeah.
Another of the newer but less typical symptoms is bendopnea. Patients reporting breathlessness on bending has been very much associated with patients with heart failure. And then we have all those kind of typical cardiac symptoms that, such as dizziness, palpitations and syncope, that may be associated with the diagnosis of heart failure. For those patients with fluid retention, many of them feel abdominal bloating and fullness, they've lost their appetite, and some of them, if they've got quite advanced heart failure, have reduced concentration and mental ability, probably because of reduced perfusion to the brain, so just slightly dulled in their thinking. Less specific symptoms are weight gain, because that can occur for any reason, but obviously associated with fluid tends to be more obvious. But we should also think the opposite. We get patients with advanced failure who've got cachexia and they're losing body mass. So when asking about weight gain, if you've got someone who's looking very frail and you're thinking, ask them about body mass weight loss. The obvious one, peripheral edema, which we often refer to ankle edema. We should think lower legs, thighs, sacrum, scrotum, ascites.
Right up.
And the other thing I would mention about in the community, we may go and do a home visit to a patient who's been bedbound for a while. Edema is gravitational. So you squeeze their legs and think, oh, there's not much there. But actually, if you squeeze the back of their calves, the back of their thighs and the sacrum, you will find lots of fluid because, of course, it's lying.
It's just
on the
pulled.
back.
That's really helpful point. Yeah.
And then there's Krebs, tachycardia, and irregular pulse. So lots of subtle little things that you can use to pull in to help identify a typical cardiac diagnosis and more likely heart failure.
Great. Actually, yeah, some of those are definitely... A couple of those are new to me, so that I spoke to the listeners too. Excellent. Okay, so as a clinician, you think, well, particularly in a patient who might be housebound, so the easiest test by far that will spring to mind for us to do is a blood test. So the clinician sends off the BNP. We get it back, and they both come back, penny preserved and reduced, both have a BNP around 1,000. And so we say, I think probably ought to send you up for an echo at this point. Should we have thought ECG before this?
I don't think you necessarily need to think ECG before. ECG should be done as part of the clinical diagnosis. Before we had BNP, of course, ECG was the test. If the ECG was normal, and therein lies a dilemma, what is a completely normal ECG? Then you are unlikely to have heart failure. However, an ECG tells us so much about things that we will take hold of in the treatment of heart failure. So it might be the patient's got AF, it might be they've got heart block, it might be they've got bundle branch block, it might be they've had previous myocardial infarction that they and we didn't know about. So doing an ECG is incredibly important to do. So it should be part of that, but it doesn't need to be done immediately. If there are the signs and symptoms and the natriuretic peptide is elevated, I would refer. Partly because nothing is ever straightforward. We are unable to achieve the NICE guidelines. I believe in Derby they currently still have a rapid access heart failure clinic. The consultant running that in Chesterfield recently retired, and that currently is closed. So there is a wait for patients to be seen. The echo request form requires you to put the symptoms and the natriuretic peptide. Please add it because your request will be triaged according to that level. Information.
Okay. But there are, unfortunately, Penny is quite an anxious patient, a bit of hospital-related anxiety. She doesn't want to go up for an echo. So we've just got a lady without echo with a raised BNP. On the basis of that alone, can we diagnose heart failure? Because there are other things that can push it up, aren't there?
Yes. So let's answer the latter bit first. There are many things that can push it up. So we've got things like age. Penny's old. We've got atrial fibrillation, tachycardias. We've got pulmonary disease such as COPD. We have other cardiac pathologies. Renal failure is a notorious one, and so does diabetes, and there's a few others as well. So we kind of have to bear those in mind, but if we look back at the NICE guidelines and the evidence is that if your natriuretic peptide is above 400 and you've got signs and symptoms, then you should have an echo. Now, I think it's worth reminding people that natriuretic peptides, number one, in Derbyshire we use NT-proBNP. There's a natriuretic peptide called BNP. The values are different, and there are some subtle influences between the two of them if you're measuring them, especially if you're on an angiotensin receptor neprilysin inhibitor. In Derbyshire and surrounding healthcare system, we use NT-proBNP. We often refer to it as BNP.
I think that's the problem, isn't it? Yeah.
So what I would say is the natriuretic peptide is a test of exclusion. If the natriuretic peptide is low, the patient is highly unlikely to have heart failure. It's not a perfect world, and I have come across a patient with a normal natriuretic peptide. Eventually we deemed that they did have heart failure. Right. But it's incredibly rare, and therefore it helps you as a primary care clinician decide, do I chase other things or do I just go straight to the echo?
Yeah.
So if it's elevated, refer immediately for an echo. Don't delay, because there's going to be a bit of a delay at the hospital end. if it's normal, start thinking other things. Take your thoughts away from heart failure.
So to take you back to the really sticky one though of we can't get the echo, but it is raised and the clinical picture is highly suggestive, symptoms and signs.
So I think the best we can do is say, based on signs and symptoms, we have a working diagnosis of heart failure, but I would not recommend nailing, is it heart failure with preserved or reduced? I have seen patients who have had heart attacks, hypertension, men, smoked. I'm leading you down the heart failure with reduced ejection fraction, their echoes come back as preserved. I've seen the elderly female lady with AF and hypertension, obviously should be preserved, who got ejection fractions of 20%. And I would do my best, in all honesty, if this patient is wanting more than comfort treatment, and you believe that if it's heart failure with reduced ejection fraction, you could successfully get them on some of the drugs, then I would encourage all patients to have an echo. We have the advantage, and I'm sure this is happening in Derby, I do have slightly better knowledge in the north of Derbyshire, we are going to have echoes out in the communities soon.
Great.
And
that's
that's a thought to think about. If I don't like going to a big hospital, what about a community location? Might that swing it for the patient? So I think unless you're going for comfort palliative measures, or the patient is adamant they don't want anything other than the basics, I would always encourage them to go for the echo.
Go that way. And actually, yes, if it is coming out further, I think for a lot of patients it's a psychological thing, but actually going to somewhere slightly more local, they'll often accept. So that's really helpful to know. Excellent. So we've talked about these different types. We've got the preserved, or sometimes it's called normal, but preserved is the current word we should be using, and reduced ejection fraction. And the purpose of the echo is really to try to delineate between these, as well as check for things like valve disease, presumably.
Yes, I think fundamentally that's what we're looking at. The sonographers are outstanding. They will always give us a whole lot more. And sometimes we see unexpected things. We might find a patient has hypertrophic cardiomyopathy rather than a dilated cardiomyopathy. We might find a patient has LV thrombus. We might find a patient, and we have come across all these kind of patients, a patient who had cancerous growth within their atrium. So whilst they're not terribly common, the echoes do tell us other things. They can also tell us about aortic dilatation of the ascending and the arch of the aorta, and the sonographers are quite clever at picking up some of the other subtleties that can be helpful. But you're right, primarily they're going to tell us about the muscular function and valvular function. Of course, certainly many years ago, I don't think it's changed, the correlation between what we hear with the stethoscope for valvular murmurs does not correlate with what's the degree of dysfunction of the valve found on an echo. So the echo is the gold standard for helping us with that.
I was encouraging a trainee the other day. They've been learning for their exams that they have to all these specific murmurs, and I'm saying, don't worry. Most doctors just write down what they hear, but you need the echo anyway, really. So
And I guess the only other thing just to mention would be in terms of valves. So we might listen to a patient and think aortic stenosis, they're a bit old, but they might have only just become a bit frail, maybe because they're developing heart failure. We shouldn't forget the new techniques such as TAVI for aortic valve. We've had some, doesn't occur with everyone, but patients have significant improvement of quality of life, which they wouldn't have otherwise had because they wouldn't have been able to undergo normal operation. That kind of decision definitely starts with the echo.
That's a good point. So we've made this diagnosis, and I guess the question is, at what point should we be referring in? So I got in front of me, in fact, the GP referral form to go into the heart failure services, and this does specifically say you must have had an echo to be eligible. So if we've got the patient, say the care home patient, in whom we can't get them up to hospital for the echo, am I right in thinking we have just got to simply manage that within primary care, or can we even is there access to phone advice or anything like that?
I think that's a really good question, Sarah. So I think it's probably worth explaining. On Pathfinder, which is where I believe most GPs would access, you'll have two referral forms.
Okay.
One is for secondary care, so that's where you need a cardiologist, and that would be the preserve of the very young that you think have got heart failure. Something peculiar, peripartum heart failure, although it's often picked up in the hospital. Someone who's got terrible angina, where you're thinking, well, the community heart failure service can't yet do angiography and PCI in the local community hospital. They obviously need the cardiologist.
Yeah.
And profound arrhythmias, all those patients, they need to go to cardiology. Cardiology is highly likely to refer them for the management of the heart failure back into the community heart failure service.
But they've other
But that patient needs to be in front of the cardiologist for the management of that bit. From a community heart failure service point of view, we have to insist that cardiac imaging is there to confirm the diagnosis, going back to what we were speaking about, because that helps us design and guide treatment with the patient. In our experience, it's rare that patients don't have an echo, but if we're thinking actually the best we can do is comfort measures, in order that we can focus our efforts on the huge numbers of patients who are quite complex and requiring lots of drugs, we would say to the GP, we need to leave that patient with you. But Sarah, you're quite right. If you need some advice or just want to check something out or have a thought about something and just want to see if it makes sense, please ring either the office in the north at Walton Hospital or in the south at Florence Nightingale and ask for one of the clinicians to call back. Little request, please don't leave the practice general number. We're busy clinicians too. Please give us a direct access number and we will get back to you.
I think I've learned that with others. It's much kinder to give a mobile and let them get through. Otherwise, it's a hopeless task sometimes, isn't it? Yeah, fine. And so, I mean, that's helpful because I was going to ask you next about, okay, how is the service set up? So that's given me a good understanding. So usually, obviously, we can pick up the phone, but it's usually there's a referral form we fill electronically and send through to the north or the south, essentially, isn't there? And is there any sort of any trends in the referrals you're getting out of interest? Anything that you're seeing a lot of, or anything that you're wishing you weren't? We could have done a bit better beforehand.
I guess there are a few things that are just worth bringing. Referrals are going up. That's not surprising. We knew this was going to happen for years. By the way, our staffing isn't going up, but nonetheless, and we also have to take account, if you think of the last 6 years, we've had brought on stream angiotensin receptor neprilysin inhibitor and the gliflozins, the SGLT2 inhibitors, and they are stepwise incremental treatments. So that keeps more patients on our caseloads for longer and we're getting more referrals. So we are doing our utmost, but we need the help to only be referred the most appropriate patients where we can make that big inroad for them. So the trend is numbers up. There often is, in my experience, probably a trend that we're just a heart failure service to see anyone with heart failure. Because that's what our name is.
Yeah.
And what I would say to people, it would help to think of us as the complex heart failure service. And complex could be a patient who has complex symptoms or a patient who it's really hard to work out what to do with drugs because blood pressure's low, renal function's dire, don't know what to do. It might be a patient where you feel the time and effort involved, maybe they have learning difficulties and we need a package of care and someone just to gently guide the learning difficulties team to help. Those kind of things refer. The other thing that's slightly different, probably it has been happening for many years now and I think can lead to some confusion. From non-acute, so I don't mean secondary care, I mean acute, I've been admitted. All other referrals other than those, we will only take patients with heart failure with reduced ejection fraction, and we are beginning to insist it must be less than 40%. In other words, all the patients that we can target all the four pillars of therapy at. Yeah.
The other drugs we should be just getting on, in the straightforward cases we should be getting on in the community.
And I'll come back to the starting. Post-discharge with heart failure, from the acute trust, we will accept heart failure with preserved ejection fraction because the greatest risk of readmission is your first admission, the greatest indicator. So to try and reduce the readmissions, which is the really costly bit to the health service, we are trying to make sure those patients are stabilised for 3 months. Unfortunately, the data goes out to 6 months. We don't have the ability to do that. So we will try and manage those patients, get them stable, and then hand them back. So GPs will see, well, you're managing that patient with heart failure with preserved ejection fraction, but you wouldn't accept the
That's
referral
why.
from me.
Okay.
That's why. The acute...
And that's useful to know as well. I was going to say how long do you have them on your books, but it's around a three months of
3
stability.
months for the heart failure with preserved ejection fraction just to check they're stable. But any patient who's been stable for a month and optimally treated is then given an open appointment with us, which is door is open for a year.
For a year. Okay, great. And then when they come back to us, are there any common pitfalls, things that you see people coming revolving around the door because things are not happening in terms of monitoring or...
I would say the biggest thing is that when we, and usually, and I think most of the South GPs are on TPP and we use TPP, I try and flag in my task to the practice, say that I put the patient on an open appointment to remind them, you know, I'm handing this patient back to you. I'll usually mention if they've got CKD as a hint that think about UNE monitoring, do you want to set it up? And I know practices use different things, so I'm not going to tell anyone what to do. But I kind of usually put, I am handing nice recommended ongoing monitoring over to yourself, which is kind of a hint. There's bloods that we're doing, there's medication reviews. And I tell the patients, and I say to them, please, when your GP sends you that letter, could you make an appointment? It's really important. It's your heart MOT. Don't ignore it.
Plenty of the frail ones for us, though, we need to have our systems because they're not going to, perhaps they've got some early onset cognitive impairment, whatever. So, we need to really be aware of that.
Yeah. And I think this is more post-discharge from hospital, but it's after they've been discharged from us. They go into hospital, let's say with sepsis. Their blood pressure was low, so all their heart failure drugs were stopped. Okay, get that. They're discharged, and the message comes out on the discharge letter to the GP. Antihypertensive stopped in hospital. Please review after discharge starts if appropriate. You read that and check the patient's blood pressure. Let's say it's 120/80. Don't need those drugs then. Move on. But they were heart failure drugs. And I have certainly, I've tried to engage, and I know why this happens. I do understand it. But I'm trying to engage with the hospitals and with primary care. Just say, have a breath for a moment. They should have put that they were heart failure drugs.
Think about why they're on...
Yeah. And I try and tell the patients that. I say, if any of these drugs are ever stopped, you must go and ask your GP why you can't restart them.
Give them some empowerment to...
to help everyone out.
Well, that was a whistle-stop tour of diagnosis, referral and a dip into the local services. So thank you ever so much. We're going to continue this conversation in our next podcast, talking about actually a bit more in terms of management, a little bit more detail on the drugs and the non-drug management and ongoing monitoring. So listen in again for that. But thank you very much today.
That's a pleasure, Sarah.
Well, I hope you, like me, have taken away lots of useful learning points for your practice and possibly to put in your CPD or portfolio too. I loved Martin's analogy of the preserved ejection fraction hearts being like the new balloons, stiff and difficult to fill, but still with some power, unlike the flabby old reduced ejection fraction ones. And definitely encouragement to get the patients up for echoes whenever we can. As always, this is the opinion of one expert in the field, so always consider guidelines and use your clinical judgment. Find us on Spotify or the DCHS YouTube channel and look out for the coming discussion on heart failure management in about a month's time. Bye for now.
Conversations in Frailty. Thanks for listening.